Welcome to the Metabolic Link, a medical and science-focused podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Hi, everyone. Welcome to another episode. Really excited to be here today with my co-host, Dr. Angela Poff, Dr. Dominic D'Agostino, myself, Victoria Field. We're going to be diving into some really interesting research today. One paper is covering blood glucose and stroke outcomes, and the other is covering aerobic exercise for Alzheimer's disease. So really looking forward to exploring these two papers with you guys.
Yeah, let's do it.
Yeah. All right, Angela, kick it off.
Awesome. So, okay, the first paper we're going to talk about today is, it was published in the CNS Neuroscience and Therapeutics Journal in September 2022, and it's titled "Higher Fasting Blood Glucose Was Associated with Worse in-hospital Clinical Outcomes in Patients with Primary Intracerebral Hemorrhage" from a large-scale nationwide longitudinal registry. And this is coming out of Capital Medical University in Beijing. So this paper was basically looking to see if something that had been noticed and previously known in acute ischemic stroke was going to hold true for hemorrhagic stroke as well. So little refresher, two major types of strokes are ischemic strokes and hemorrhagic strokes. Ischemic stroke being when blood vessels, when a blood vessel is occluded, usually by like a blood clot, and in the brain, and it prevents blood from flowing to a region of the brain. That brain tissue can die, of course, and that is an ischemic stroke. Now, this is different than a hemorrhagic stroke where the blood vessel bursts and you have a brain bleed. And if you think about it, you have kind of like the same outcome. So the region of the brain that was being fed by that blood vessel in both outcomes, in both situations, is still no longer receiving that blood. So they're both strokes, but one is caused by occlusion of a blood vessel, that's ischemic stroke. One is caused by bursting of a blood vessel, which causes bleeding into the brain. Ischemic strokes are the most common, and hemorrhagic strokes are a lot more rare, but they're very deadly because, of course, in the brain, when blood is pulling in the brain, it puts pressure on this important tissue, and there's not a lot of room for blood to collect in the brain. So ischemic strokes are very dangerous. And it had been known previously that hyperglycemia following an acute ischemic stroke was associated with a poor outcome in that condition. And these researchers were wondering, is that true as well for intracerebral hemorrhage or a hemorrhagic stroke? So they performed a retrospective analysis of a large cohort data set from the China Stroke Center Alliance. And essentially what they did, they looked at the fasting blood glucose that was taken on the second morning following their admission to the hospital. And they stratified the groups into three categories depending on their glucose level. And it was the lower range was 3.9 to 6.1 millimolar, and then the middle range 6.1 to 7 millimolar, and then above 7 millimolar. And they looked at the different outcomes of in-hospital mortality and the percentage of the evacuation of the intracerebral hematoma. So this was a way to estimate the hematoma expansion. And they were looking for relationships between these variable glucose levels and the outcomes that they listed. And they also wanted to consider a couple of potential confounding factors. So they considered subgroups including history of diabetes, whether or not that individual had ever taken anti-diabetic medications, and if their hemoglobin A1C was above or below 7. So basically, when they analyzed this data, compared to the individuals in that lower range group, so the 3.9 to 6.1 millimolar glucose, the fasting glucose, the individuals in the two higher glucose groups did have a higher inpatient mortality and a higher proportion of evacuation of the intracranial hematoma. And this held true even when controlling for those confounding factors of whether or not the patient had diabetes or had been treated with anti-diabetic drugs, and their hemoglobin A1C. So really, clearly supporting that post-stroke glucose levels are at least correlated with how well someone's going to do in terms of their prognosis following stroke, and seeing this both with ischemic and, as was previously reported, and then in this case, hemorrhagic stroke, which was really interesting. And, as a metabolism researcher, I don't find this surprising. It's something that I think is really interesting because we look at lots and lots of neurological diseases, including like traumatic injuries to the brain, TBIs, even concussion, things like this, epilepsy, neurodegenerative diseases. You have this dysregulated glucose metabolism that occurs. And a lot of times you'll have like a period of like hypoglucose metabolism where glucose drops low and then it rebounds, and you might have a hyperglycolytic period as well. And that abnormal dysregulated glucose metabolism, that perturbed brain energy supply, is really associated with a negative outcome in a lot of these conditions.
Yeah, and the elevation of glucose, the hyperglycemia, also comes with a lot of metabolic baggage, I guess if you will. And I don't know, well, you didn't mention it, and I didn't get a chance to go through it, but I would assume that there's probably a higher level of insulin, hyperinsulinemia associated with the hyperglycemia. And we know that as your blood glucose gets elevated, that will increase the viscosity of your blood in a way that it's limiting the perfusion, or in this case, the reperfusion. And so higher glucose would be associated with perhaps higher insulin, and that could be driving pro-inflammatory cytokines, maybe in the microenvironment of the ischemic area, and typically associated with higher blood glucose is sort of maybe markers of organ function, like non-alcoholic fatty liver disease, which we saw in our patients who were essentially normal glycemia. And then that's typically associated with higher inflammatory markers. And I think that could be coming into play here. Probably not measured, probably not one of the outcomes that they're looking at. But also, I mean, we know that glucose levels, as I mentioned, is associated with increased viscosity of the blood and blood flow in general, but also the lymphatic system. As your glucose gets elevated, a big part of brain repair and recovery is the lymphatic system that we have in our brain, and termed the lymphatic system. And that's directly proportional to blood glucose. So I think during the rest and repair phase, which happens during sleep, that would likely be impaired too if these subjects have hyperglycemia.
Yeah, there's a lot at play here. I'd love to hear a little bit more. When you've got elevated blood glucose levels, I feel like, in terms of outcomes, what are some of those mechanisms? Like, I'd love to hear, I know you briefly mentioned a couple things going on within the brain, but there's so much more to that. And it's, as you said, not really surprising, but interesting. I do wish that they had tested insulin. That would have been a fascinating marker. But Angela, were you going to comment on that?
So they did mention a couple of things that, there's been a lot of preclinical work in this kind, in like stroke or TBI and these kind of model systems where it's possible to try to tease apart some of these things and exactly what's going on. And so, I think one thing to keep in mind is just how exquisitely sensitive the brain is to energy disruption. So neurons communicate through a chemical electrical signaling and called neurotransmission. Neurotransmission is very sensitive to imbalances in energy. It takes a lot of energy to maintain normal membrane potential, and once that's disrupted, to return it back to normal kind of operating capacity. So when you have this energetic perturbance that occurs, for example, in stroke, remember that blood is carrying the nutrients, glucose, and whatever nutrient is feeding that tissue to that tissue. All of a sudden, that tissue is now starved of oxygen. It's also carrying oxygen, of course. So these neurons in that region are now starved of their energy supply, they're starved of oxygen. You're going to have mitochondrial damage, oxidative stress immediately happening because, well, you don't even have oxygen. You can't maintain oxidative phosphorylation rates if you don't have normal oxygen supplied to that tissue. And that can cause membrane potential issues, which can disrupt the way that the neurons communicate. And so if oxidative phosphorylation is shutting down, then you're going to, rely on fermentation. And that's one of the mechanisms that they were saying might be underlying some of this damage is excessive lactate production. So if you guys remember, lactate is the end product of glycolytic fermentation or anaerobic fermentation. So excess lactate is an acid, it's got to get exported, gets into the microenvironment, can have some negative effects there.
And I'd like to add, directly proportional to mitochondrial function, or in this case, elevated lactate dysfunction.
Yeah.
And the mitochondria are the source of reactive oxygen species, which can then produce superoxide and other reactive intermediates, and then trigger inflammatory cascades too on top of that. So that lactate accumulation is indicative of impaired mitochondrial function.
Yeah,
Yep.
Absolutely. And you have the free radicals being produced because of that, as you mentioned, Dom. You have oxidative stress causing damage to the lipids in the cell membrane, in the mitochondrial membrane. You start seeing calcium being released inappropriately, and that is can trigger cytotoxicity and cell death. So it's kind of like like the floodgates kind of open, I guess, when you have this breakdown of the energy balance.
And you mentioned the membrane potential, which is dependent upon mitochondrial function.
Yeah.
And then that membrane potential being compromised or more depolarized will dump glutamate into the microenvironment. And then glutamate will be activating AMPA receptors and NMDA receptors, and that can trigger a calcium influx, which can then set off the cascade for apoptosis or necrosis, depending upon the microenvironment. But all dependent upon, glucose being maintained. So higher glucose would, be impairing that blood flow. And then all these events that I just discussed would be very interdependent upon that.
Yeah. Giant metabolic waterfall of
Yes.
a hot mess. It sounds like. I mean, this is really interesting though, because having being armed with this kind of information, knowing that if you have elevated blood glucose levels, it can lead to worse outcomes in these kinds of situations. I mean, obviously, there's so much to be said here about potential of prevention and things along those lines. We briefly touched on insulin being a marker, which I think is really interesting, and they didn't, I don't believe, measure insulin in this study, but it's something that's like a big topic of discussion where, if we measured something like insulin, like we could know about, this person's issues with glucose metabolism way sooner, right? Because it could take 10, 15, a long time before you start to see these extreme levels of blood glucose. So hopefully we start to see that a little bit more. I mean, talk to that a little bit in terms of, why sometimes we don't go to that marker first, and maybe that's changing. And it seems like it's changing anyway, fasting insulin.
Well, I think there's probably methodological reasons why we don't, that insulin is not part of a comprehensive metabolic panel. But if you take, 100 people and they all have normal fasting glucose, especially in a more aged population, it's highly likely that a subset of those people are producing considerably more insulin to maintain that normal level of glucose. So as we age, if our glucose does not go up, that doesn't mean that our insulin is not going up proportionally over time. And as we age and we become more insulin resistant, it takes a lot more insulin production by the beta cells of the pancreas to maintain that glucose level. And essentially what happens with type 2 diabetes is that capacity to maintain blood glucose fails, and then you have skyrocketing glucose on top of hyperinsulinemia. But if you could observe insulin, years prior and see that creeping up over time, then you could get ahead of the situation and mitigate it through dietary interventions or perhaps pharmacological interventions to kind of stall that cascade over time. And the insulin, independent of glucose, will be contributing to a number of different factors that could impact the outcomes discussed here. So with brain health and organ function and the state of, the systemic inflammation.
So we could grab a hold of it before it becomes this big emergency. I've had family members where all of a sudden, blood glucose levels are 400 and above, and they feel super motivated to change it. But it's like, gosh, if we had just known this when it was probably first starting to happen with a fasting insulin level, that could be, 10 years down the line. I mean, granted, you're doing something now, so that's better. Sure. But it's an interesting marker for sure that I think, more and more people, fasting insulin hopefully becomes more of a staple in looking at overall metabolic health. One thing I found that was kind of interesting in this paper, and we can kind of dive into, is that they share that their findings are consistent with a large observation analysis that actually showed that elevated admission blood glucose indicated a higher risk of poor outcome in non-diabetics than diabetics with similar glucose levels. And you first read that, and you got to read it a couple of times, because you might not usually think like a non-diabetic would have a higher risk of poor outcome over a diabetic. And they point to things like stress and insulin resistance, but maybe it's a management thing, right? Maybe they already know they've got diabetes, and there's a stressful situation going on where a non-diabetic is getting all this information at once. Who knows? I mean, what are your thoughts on this when you guys read that comment in that paper?
Well, you just read it to me. So
you're welcome, Dom.
I didn't, but at first, just thinking about this offhand, counterintuitive, but like you had mentioned, I think you kind of hit the nail on the head, is that if you have diabetes, you're aware of the problem, and then you are proactively managing the problem with you and the doctor. So I think in the context of this situation, maybe that proactive management may be really intertwined with the outcome too, or the outcomes, because this is a prospective study or retrospective. That's what I meant. Okay. Yeah.
Well, and I think maybe the pessimistic mind of mine goes, well, maybe they're just undiagnosed. And I do think that's a huge problem. I think there's a lot of people walking around out there who don't have any idea that they're pre-diabetic, or maybe
100%.
have super high insulin that's barely keeping everything in check, and they're right on the precipice of actual diabetes, or they really probably have it and then don't even know. And I think that's a massive problem just in general.
Right.
So true. I've done health screens where we just measure people's glucose, and we've had people 400, a couple of 400s I recommend, and these were like young people that had no idea that they were at that level. So
and it's not always, associated with some of the things that you might think for type 2 diabetes. There's other, hallmarks of metabolic dysfunction. I know that there's it's on the rise where an individual can be, lean and otherwise seemingly, healthy, and maybe doesn't have the obvious risk factors, and still having, really scary, blood glucose
Totally.
levels.
I mean, sleep disruptions and things like that you wouldn't think is maybe a symptom of something like insulin resistance, but you're having trouble staying asleep, or without eating food right before you go to bed, or things along those lines that people don't automatically kind of associate with, like, maybe I have a blood sugar issue. But I really noticed a significant difference transitioning my diet from, really high carb athletic, when I was competing professionally, it was like I constantly had to eat to stay satiated, not get super lean. And at the time,
get hangry, right?
And hangry, totally. And at the time I was like, wow, this is great. I can eat basically all that I want, 4,000 calories. But in transitioning onto a ketogenic diet, I really noticed, monitoring blood levels and all of that, I really noticed such a significant difference in terms of like sustained energy and all of those things that I think I could have been developing something like insulin resistance if I had continued down that path of like high carbohydrate consumption, even though it was great for my athletic performance at the time, potentially. One could argue maybe if I was keto adapted, I would have been better. But it's interesting to think about those things that many people, even those that look healthy or maybe even are athletes can be dealing with something like this without even knowing about it.
Yeah.
Well, that invites the question. I mean, getting back to the paper, I think, the things that you experience on a ketogenic diet with metabolic stability, the elevation of ketones, and the lowering of blood glucose and insulin could be a great therapy for someone who has just experienced a stroke, and even fasting, especially if they have, glycemic dysregulation, to fast that patient. And not put them on a sugary medical drink or TPN or something like that. So,
and I know there's trials ongoing.
Yeah,
Right? There's a lot of active research. It's definitely not, standard of care, anything that's like been proven right now. But the theoretical mechanisms underlying what you just said really does make a lot of sense. The neuroprotective effects of ketosis. And there's a lot of trials right now trying to see if that could be therapeutic in that setting, which is cool.
Yeah, it's really exciting and much needed. I mean, we're in a place in society where 9 out of 10 people are metabolically unhealthy, and this is just, we need this kind of research to be happening to understand how maybe we can avoid such terrible outcomes, have a different way forward. So,
well, I was just gonna, before we leave this paper, I was gonna say, there was one thing that kind of struck me about it, was that it was kind of like the elephant in the room. They didn't really talk about really the importance of diet and things like that. And of course, that's the biggest tool in controlling
that's where we
your
come
glucose levels. Right. Now, of course, there are alternate things at play following, a traumatic event like this. You have a neuroendocrine response that stimulates, cortisol release. You have glucose elevation that's caused by that, right? But regardless of what someone's eating, if they have a stroke, they're going to have this cortisol-induced elevation, hyperglycemia. Now, but if you think about it in the context of someone who already is insulin resistant, that's going to, make that response more severe, perhaps prolong the time frame at which the glucose is elevated. So, it has to be acknowledged. I think the background metabolic health of an individual in so many cases dictates their response and recovery, because are you able to get back to a healthy place? And if you're already healthy to begin with, obviously that's a lot easier to do.
It would have been great to see a comprehensive metabolic panel to get a snapshot of the overall metabolic health of the individual, and I bet you could probably find some things that correlate tightly to the outcomes of that. But,
and not to bring up a subject that I'm sure everybody's sick talking about, but I think the pandemic really brought to light how much control we maybe have in terms of metabolic health. Granted, I was somebody that, it went a little sideways for me, and everybody's different. But I think that, even from something like what we were dealing with this virus, we knew that if you went into it metabolically unhealthy, things weren't going to be as good for you on the other side. So it really, I think, brought to light this conversation and is creating more discussion around the importance of metabolic health, especially when we're thinking about maybe disease prevention, or at least lessening the experience if you have to go through something like that.
Absolutely.
So we've got another excellent paper here that I'm excited to dive into. This one is titled Aerobic Exercise for Alzheimer's Disease, a randomized controlled pilot trial. And Dom, I'm going to let you kind of dive in. I know you've taken a good look at this one and share a little bit more.
Well, I just looked at it this morning, hot off the press, although it's 2017. It's a PLOS One paper. We're familiar with that journal, good journal. Title being, Aerobic Exercise for Alzheimer's Disease. And really, this particular study was investigating more or less the cardiorespiratory fitness hypothesis towards Alzheimer's disease. And they use the gold standard of cardiorespiratory fitness, which would be the VO2 max, and kind of looked at that. But they looked at a wide variety of different assessments to basically determine, to characterize the people who had Alzheimer's disease. And specifically for this study, it was people with mild cognitive impairment or mild Alzheimer's disease. So this particular group was from the University of Kansas, and they have an Alzheimer's center there. They've looked like they collaborated with the Brain Imaging Center, the biostatistician, the Physical Rehabilitation Center, and they had a really good team, but it was just really confined to this area in Kansas, and it was a good collaborative effort. Jill Morris being the first author, and Jeffrey Burns, who's published previously on Alzheimer's, is the senior author of this. So they really focused on, they had a pretty aggressive recruiting protocol that we'll get to that later. But the idea here, or the overarching sort of specific aim, was to compare aerobic exercise and the cardiovascular benefits you derive from aerobic exercise, the hypothesis being that those benefits would translate to increased functionality and increased cognitive function in people with mild cognitive impairment or mild Alzheimer's disease. And then that group was compared to, if you want to call it the control group, that was more like stretching and toning. They labeled the ST group. And the stretching was just a series of stretching exercises done within a predetermined time frame, and the toning was Tai Chi. There was yoga associated with it. So it was one group aerobic exercise, zone 2 exercise, where they ramped up over the course of 6 weeks, I think, starting out at 50, maybe 40 to 50% of their max heart rate, and then ramping up over the course of 6 weeks. And which it would have been great to see the effects of aerobic exercise and the stretching and toning together. So, but this was a pilot trial that was really done to assess specifically aerobic exercise with the goal of doing a bigger trial in the future. So, a little bit of background on kind of exercise and Alzheimer's disease, which we kind of highlighted at prior Metabolic Health Summit conferences. Tommy Woods really focused on a muscle-centric sort of scenario. Building muscle releases myokines, and a good marker of overall, health and wellness. And so this kind of contrasts that, in that the toning exercises were kind of muscle specific, whereas this group was really specifically focusing on aerobic exercise or cardiovascular fitness. So prior work done in animal models, and there has been quite a lot of work done in animal models, and I mean, this goes back to some of the work that we did at USF at the Alzheimer's Center, actually predates your PhD in 2009, looking at, exercise and caloric restriction, and you get amazing improvements in physical function, in body composition, and this is a bit controversial, tau and amyloid plaque accumulation over time, at least in the transgenic animal models, double and triple transgenic animal models. So that seems to move the lever on that. So the etiology of Alzheimer's disease is kind of like multifactorial, and it is being diagnosed with Alzheimer's disease is a requirement is to have an accumulation of amyloid plaques, amyloid and tau. So we didn't know from the previous work in animal model systems that exercise impacts brain health from a number of different scenarios. So there's a neurotropic effect. So when you exercise, it increases a variety of growth factors, including neurotrophic factor, brain-derived neurotrophic factor. There's a neurogenic effect, just activating motor neuron pathways. And there's a vascular effect. There's an increase in brain blood flow. And also exercise is intimately linked, and it's depending upon dose, and it doesn't take a huge dose, to overall brain size and atrophy. So you could reverse hippocampal atrophy with exercise. So that's pretty apparent in the animal literature, and observational studies in humans suggest, and that really leads into this particular study, and there's a number, about a half dozen studies sort of referenced in the intro here, that cardiorespiratory fitness and your overall physical activity level or fitness level is associated with a greater brain volume and less brain atrophy and slower onset of dementia and reduced risk of dementia over time. So that really forms the basis. There's compelling data in preclinical animal models and compelling observational data, epidemiological data in humans to suggest that exercise is a low-cost, easy barrier to entry. Well, in those, exercise is not always super easy for everybody to do, but it's probably the biggest lever that we have, considering that there are no drugs to effectively treat Alzheimer's disease or reverse it, only to manage the symptoms. So exercise seems to be our best option. So this was a nice study designed to look at that. And so the overall objective, it was really a pilot study to establish preliminary efficacy of a community-based project here in Kansas. So it was, the prescription of exercise was 150 minutes of moderate intensity aerobic exercise, and they looked at cognition, various tests for that, functional ability, depression, and with the non-exercise, and we had mentioned some of the toning exercises. They didn't really go into too much detail about that. And their marker of cardiovascular fitness was the VO2 max. So, with that, kind of getting into some of the how subjects were recruited. Generally speaking, it said for the inclusion criteria that most of them were largely sedentary. So one would expect that any type of exercise intervention, be it aerobic exercise or, quote unquote toning or stretching, would have, significantly positive impact on a variety of things that should impact the outcomes. The exclusion criterias were things that you would find: psychiatric, systemic infection, stroke, MI, and so just getting into how they randomized things. And do you guys have any questions?
No,
because I was going to go into the actual sort of protocol. So to assess eligibility, they started with almost 250 patients and excluded some for various conditions, including insulin-dependent diabetes, which was 23 of them had that, and severe cognitive impairment. So once again, this is for mild cognitive impairment or mild Alzheimer's disease, orthopedic issues that would prevent them from doing the exercise protocol. So from almost 250 patients, 248, they randomized 76 patients were selected based on the inclusion and exclusion protocol, and 37 went into the stretching and toned, and 39 into the aerobic exercise, which once again was 150 minutes per week. And they worked with a trainer initially for the first couple weeks. There was not a whole lot of information to sort of validate in my eyes that the training time or the intensity of the training there was no graph of that. So
I wonder if there was a supplemental.
It'd be great to know, like, how,
I'm not sure if they had
in terms of muscle mass and what they were doing specifically, like what was the intensity of the strength training. Like you mentioned, Tommy Wood brought up at Metabolic Health Summit a really great point around training. I think he was discussing cancer, I think he was not bringing up cancer patients specifically.
Thinking of
Colin Champ.
Yeah.
Sorry,
Champ
Tommy.
had a great presentation.
But I mean, both of them are talking about the importance of muscle mass in their presentations. But Colin Champ was talking about how he takes sort of this approach of, let's not just do like the 3-pound weights. Let's actually do more functional, like compound, deadlifting, squats, things along those lines, and not treat the patient as so fragile, but instead like, hey, this is an opportunity to use muscle mass for what it's good for in overall health.
And when it's done responsibly in like a slow way that, is safely, because obviously like, falling is a huge risk for this patient population. And I mean, but that is, I remember Colin talking about, he put up a picture of an elderly cancer patient who was like, I mean, I don't even remember what she was pressing. It was some like huge, very large weights. And he was like, I'm not worried about this lady falling. You know what I mean? Like, and that, so it's not even just the overt immediate benefits, obviously, of exercise. but like preventing some of these age-related, effects of like sarcopenia and other atrophy that occurs in this population that makes it super dangerous for them, even doing, tasks of daily living.
Loss of function, things decline very rapidly. You have 5.3 million people, I think, has Alzheimer's disease, and that's going to double in 2050. That number is going to double, right? So, and we know that exercise, greatly enhances structure, function, hemodynamics, by altering a whole host of metabolic parameters. So, and these things are going to be tightly linked. Whatever is good for the heart, we know it's not even disputed, but whatever enhances and protects the heart and makes it function better is going to protect the brain. So all the data indicates that whatever is cardioprotective is going to be neuroprotective or brain protective.
Totally. I think it's looking at the patient as a whole person, right? And really addressing lifestyle, environment, all of these factors that of course influence. And it's exciting to see, I think, as an example of, in this paper, that the research is headed in that direction where it's including some of these factors and epigenetics and all of these things that come into play with exercise, food, sleep, stress, that I think play a major role and need to be a part of the conversation.
And like you said, thinking about the whole person and, respecting the agency of these individuals. It's dementia is such a cruel disease, and they lose so much of the life that they knew and were used to. And even just thinking about the ability, so there's a huge correlation between like depression and Alzheimer's disease.
Absolutely.
And thinking about like exercise supporting mobility, and if a patient is has greater mobility, being able to do things like they used to be able to do, that gives them joy, that maybe they get to play with their grandchildren more, they're able to physically, and then that could have cognitive benefits aside, and like mental health benefits aside from just like
it's like a big
supporting the brain.
So bipolar, schizophrenia, schizoaffective disorder, depression, all these things are, and it come to my attention that bipolar is several fold higher. I think it might be up to 4 or 5 times higher with one report if you have Alzheimer's disease. So and that ties into another theme that we have been trying to advance and get more attention for is metabolic psychiatry. Chris Palmer and the Bezucki Foundation are advancing that quite a bit. And I think, maybe a lot of those efforts are focused on the younger population, but there's a huge need in the Alzheimer's population or early dementia. And quite a few people were excluded because of psychiatric disorders. So, but, so getting back to the actual, what did they do, the intervention, there was a test that I was not familiar with, which was the Disability Assessment for Dementia Test, or DAD. And then this was, and I kind of remember it because it's like, the things that you do for daily activities, the DAD test. And it's very good in that sense, in that it's a wide variety of tasks which would correlate well to daily tasks that people do. So there's a number of publications on this. I wasn't that familiar with it before reading this paper. But in addition to this test, the DAD test, they did cardiopulmonary testing, and they looked at VO2 max, and they also did an MRI, which looked specifically at the hippocampus, the region associated with learning and memory, and hippocampal atrophy is tightly correlated with memory impairments. So, and also hippocampal atrophy has been shown in a robust way to be prevented by exercise previously. So this was a 26-week study, and they did at baseline, they did the neuropsychological testing, the cardiopulmonary testing, and the MRI, and then they repeated the neuropsychological battery at week 13. And then at week 26 again, they repeated everything that was done at baseline, the cardio function testing and things like that. And so being that the patients did have dementia, early Alzheimer's disease, one of the questions I had was the intensity and the oversight of the exercise. They did have a trainer in the early part of it, but it would have been nice to see that some level of, some kind of oversight or documentation of the actual, and it was kind of vague, the stretching and toning exercises, specifically what they did and how the time and intensity was controlled for that. We do know from previous studies that, kind of holding to that no pain, no gain kind of thing, that exercise intensity will kind of dictate exercise. A small dose of exercise can go a long way, but the exercise intensity, especially over time, is sort of needed to make robust changes for cardiovascular, but I would imagine for brain health too.
I mean, are we talking powerlifting? Are we talking Zumba? I mean,
Yeah.
those things make a difference, and it's good to know, much like with dietary studies where you don't really get the full scope. There's so much at play there that can differ person to person, trainer to trainer.
Synergy between the two too. So it's looking at kind of one or another, although it's not really looking at resistance exercise. So toning, I guess, would maybe fall into that category. But I just want to mention too that, and just kind of looking at the study population in general, that the stretching and toning group, 70.3% were ApoE4 carriers. And only 46% of the aerobic group was an ApoE4 carrier. So they were randomized, but they didn't.
Been randomized.
Yeah, that was the only like everything else was kind of, kind of equally distributed. The age was a little bit higher in the aerobic exercise group, 74.4, whereas 71.4 in the stretching and toning group. Many mental status tests were basically almost exactly the same. Everything else, including the VO2 max, were very equally distributed with the randomization. So, getting into the outcomes of the effects, there wasn't like a huge, robust outcome for these things here. And that's about when I stopped kind of reading the paper. But I kind of I skimmed it and looked at, went to the discussions and some of the correlations. And it wasn't, there wasn't really super robust outcomes here. They did find
between the groups, right? So
between the groups, yes. So between the groups, so there was beneficial effects. They did find that exercise-related change in VO2 max, which is the gold standard, was related to change in both memory and performance, but also the bilateral hippocampal volume correlated well. So and this goes back to the theme, your overall cardiovascular fitness is probably, we don't kind of talk about it that much, is probably the most important biomarker of metabolic health. And even there was some studies, even like your lung capacity was, correlated with longevity, was a marker. I was reading a few papers on that, and that was kind of new to me to think that, something as simple as like your lung capacity. But VO2 max highly correlated, and surprisingly, kind of just drawing a sentence from the paper, they did not observe a significant group differences, which is what I was talking about, in the exercise-related gains in cardiorespiratory fitness, just a 3% gain in cardiorespiratory fitness. So that is why I kind of questioned, this does not align with my knowledge of the exercise studies that were done with an exercise intervention, especially in like what this paper is saying is an untrained sedentary group. So to do 26 weeks of moderate aerobic exercise with a trainer up front and to only get a 3% gain, but keeping in mind that they have been diagnosed with a chronic disease that is maybe rapidly advancing age-related chronic diseases from a more of a global perspective, so they might essentially just be aging faster, cardiovascular wise.
Yeah, and I think that, keeping in mind that there's a lot of, and they acknowledge that there was a lot of variability in the outcomes. And so while neither of the exercise groups was directly associated with improvement, in cardiorespiratory fitness or some of these executive function, memory, cognitive function outcomes. When you did a sub-analysis of the data and just looked at the relationship between cardiorespiratory fitness and these cognitive outcomes for all of the individuals, there was a correlation. So, there could have been, some individuals who very strongly did have, there might be like a subgroup within this data set of individuals who, in response to whatever training they were doing, did have a pretty robust benefit. And that stuff can kind of get lost in the data. And kind of what you were talking about, Victoria, a lot of times these types of trials, exercise, diet trials, we see this a lot. It's hard to really control. It's not like a pharmaceutical drug where an individual takes a pill twice a day for 6 months. That's exactly what they did. I mean, to the variability between one individual doing this exercise routine versus what the other individual is experiencing is massive. And same with like diet. I mean, like that, what is a diet? It's made up of like hundreds of items.
Yeah, and diet and exercise are kind of like semi-voluntary. So they're part of the study. They're, didn't mention, but I think they might be getting paid. I don't know. But they're part of the study, but they need to do this. So they're prescribed to do this. And they may not be super enthusiastic about doing it. And there might be some people, that's why it would be good to have some kind of oversight on the intensity of these things. You might have some really overzealous yoga people in the in the stretching and toning group that really kind of took a liking to it and maybe did it in a way. But I think we know this from the animal data is that if you force an animal to exercise, if you put them on a wheel and make that wheel turn and then force them to exercise, that produces a different set of outcomes than if they voluntarily, give them a wheel and they jump on and have fun whenever they want to.
Like internal motivation.
So and I think that's a big factor here. Obviously, they wouldn't agree to the study if they weren't, but as as even a fitness competitor, sometimes you don't want to jump on that treadmill at 5 a.m. and do your thing. It's kind of like you're forced to do it.
Everybody has a different tolerance for getting uncomfortable too. And so, especially for a group of people who are maybe sedentary previously and aren't used to pushing themselves outside their comfort zone to get the intensity that might elicit like the type of result or gain that you might want, a bigger result than I think you said 3%. Everybody is so different. And two, it's really hard probably for a trainer to get to know that in a patient, within a short amount of time and really understand how far they can push them. And also there's, there can potentially be the trainer just understanding that they have, maybe they don't know that they have early Alzheimer's disease, but there's so many factors that come into play and especially with exercise and people's tolerance for exercise that I think it's exciting though in the fact that like there's research that's leading us to things that are in our control, like something like exercise, knowing that there's this low risk, low cost thing that we can just walk outside, potentially, not all people, but a lot of people who maybe are suffering from something like this can do something.
Or maybe have it in their family history.
Right, exactly, and be proactive about it and be like, I know from some of the research that exercise might help me when it comes to improving memory or what have you. So it's exciting to see the research is headed this way, and we'll certainly keep everybody up to date on where this is going. And this is the whole purpose of this podcast, is to explore this cutting edge information that isn't always translated to the public. So I loved our discussions today, guys. I think that we've got so much more to cover, and we'll be putting out these episodes, at least a couple every month. So make sure you guys subscribe. If you're enjoying this information, make sure you leave us a review, because that's how more people can get this information and we can elevate the science on metabolic health and therapy. So thanks, guys, and thank you all for joining us.
Thank you.